Hello, welcome to Atopic Dermatitis and its comorbid conditions. How knowing about them will help guide your treatment decisions. This is presented by Global Education Group in collaboration with the Asthma and Allergy Foundation of America, broadcast on immunologylive.com. My name is Dr. Angela Lamb. I'm an associate professor and the vice chair of clinical operations in the Department of Dermatology in the Icahn School of Medicine at Mount Sinai. Activities on Immunology Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Anne-Marie Singh. She's the Associate Professor and Interim Division Chief in the Division of Allergy, Immunology, and Rheumatology in the Department of Pediatrics at the University of Wisconsin School of Medicine and Public Health. Thank you, Dr. Singh, for joining us today. Let's get started. So first, these are our disclosures. Here are also the learning objectives. Evaluate the current evidence, including long-term safety data and impact on quality of life for currently approved agents for the treatment of moderate to severe atopic dermatitis. Also explain how the presence of comorbidities can influence the treatment of moderate to severe AD. So this is just a quick word about how exciting this program will be. It's going to be interactive. We're going to have cases and points, counterpoints. In each section, we're going to be able to provide you with some very practical pearls. We think that is definitely one of the strengths. Dr. Singh, do you have any comments about that? Wouldn't you agree?
No, absolutely. And I think another thing would be the unique opportunity to have a dermatologist and allergist together, kind of our two different perspectives and how we approach it. I think I'm really excited for it.
Great.
Okay, so I'm going to take over, talk about the first section, and this has to do with the comorbidities associated with atopic dermatitis. So we just went through this process with the American Academy of Dermatology to kind of update our atopic dermatitis guidelines, and one of our most recent publications was related to comorbidities. And, having atopic dermatitis on its own, significantly impacts the patient. But in addition to that, there are a lot of other diseases that can go with atopic dermatitis. And so if we focus in for a moment on the type 2 inflammatory disorders, or kind of our allergic disorders that are with a type 2 immune kind of underpinning. This is some data from the US that shows, 51% of patients that have moderate to severe atopic dermatitis are going to have another allergic disease or type 2 inflammatory disorder. And so if you look across the bottom of the slide, it kind of shows you the proportion of patients with each diagnosis that have the other allergic diagnoses. And so the first thing to notice is the bars are large. So there is a lot of overlap between these allergic disorders. And now if you focus in on the right-hand side of the slide, those are our patients with moderate to severe atopic dermatitis. And you can see, 31% are also going to have asthma, 41% will have comorbid allergic rhinitis, and 3% will have chronic rhinosinusitis with nasal polyps. So kind of a subset of severe allergic rhinitis. And again, just kind of illustrating how common it is to have kind of multiple disorders in addition to the atopic dermatitis. And it's not just these Th2 or allergic conditions that are associated with AD. And so this is data kind of from those the atopic dermatitis guidelines that we put together. And when we did this, we used the grade system for grading the evidence, and then based on the strength of the evidence and the number of participants in the studies, we can make a determination of kind of how strong that association is. And so you'll see there are kind of three different shades of blue on the slide. The darkest blue is, there was basically a very clear association with clear evidence and a large effect on the patient population. The teal color, or the middle shade of blue, means it was probably associated and the evidence has a moderate effect. And the lighter blue still is associated. We think it's probably associated. It's just the evidence is a little bit lower quality, perhaps because there were fewer studies or smaller number of participants in those studies. But what you can see is that, patients who have atopic dermatitis have not just these Th2 comorbid conditions, but other immune-mediated conditions such as alopecia areata or urticaria, and then other diseases that are strongly associated, which may be related to the disease itself or the sequelae of the disease, such as anxiety, depression, skin infection, and bone health. In addition to that, there are other mental health and substance use disorders that are listed on the slide, as well as cardiovascular diseases. And we think that has to do with some of the systemic inflammation that is going on that increases your risk for the cardiovascular disease on the slide, as well as metabolic disorders. So again, all of this data taken together strongly suggests that AD is a systemic disease affecting multiple organ systems in a variety of mechanisms. So if we focus in on, these Th2 type diseases, a question often is like, why is it that patients with atopic dermatitis are at higher risk, or why do they have more of these allergic diseases? And the reason for this is shown in this slide, and I know it's a little bit complicated, but I'll talk you through it. But the most important thing to note is that no matter what the mucosal barrier is that we're talking about, whether it's the skin or the nose or the airway, what's happening right past the barrier is the same, and that's common. And so that's what's illustrated on the slide here. So the top of the slide is showing all three of those mucosal barriers, the left being the skin, the middle being the nose, and the right side being the lung or the bronchial epithelium. And it is that epithelial layer that is our interface between our immune system, our body, and the environment, whether that's an allergen, bacteria, or irritant. And once, no matter what that environmental trigger is, crosses through that epithelial barrier, again, skin, nose, or lung, what happens next is common, and that is activation of our epithelial cytokines, the so-called alarmins, TSLP, IL-22, IL-33, IL-25, IL-33, and then that kind of tilts the immune system when that gets activated towards the Th2 arm of the immune system, with activation of the innate lymphocytes, our ILC2s, generation of IL-4, 5, and 13, which then cause the effector part of the immune response, meaning the generation of the allergic antibody, or IgE, and then, activation of mast cells, basophils, eosinophils, T cells, B cells, etc. And so then when all that happens, when it happens at the skin, that's where you see the atopic dermatitis. When it happens in the nasal epithelium, that's our allergic rhinitis, and obviously in the lung is asthma. And so just illustrating that there's this common pathophysiology, and it can start in one mucosal barrier, and once that immune system is turned on, it can then kind of go to those other mucosal barriers. So just kind of illustrating the role of the environment in that Th2 disease. And why this is important is because, having moderate to severe atopic dermatitis by itself, that's enough, right? Like that's enough to impact how you live, how you sleep, itching and all of that. But not only that, now not only do you have the skin disease, but now you have other disease burdens that we've talked about on these previous slides, including, type 2 comorbidities. And because of that, now we've kind of compounded the effect, and this can now negatively impact the quality of life of the patient and kind of be worse with the more conditions that you have. In addition, these patients can be refractory to the treatment for their primary disease. And what's lovely, though, is that optimal treatment of their atopic dermatitis and their comorbidities can really improve their quality of life. And so we know that these high prevalence of Th2 comorbidities and moderate to severe AD really highlights the importance in our role in assessing for comorbidities in our patients, and then using an integrated multidisciplinary approach to address the quality of life and patient outcomes. And so, we've kind of focused in on the immune system up until now, but, something that has become really clear and obviously is very important to our patients are the strength of these mental health comorbidities. And what we find is that patients with especially moderate to severe AD, they are at higher risk for both depression and anxiety. AD is associated with a twofold higher risk of either self-reported or clinician-diagnosed depression among adults. And it's also associated with an increased risk for anxiety. And the question is, why? And this could be related to the disease itself. There's a lot of data now on like neurogenic itch and kind of the role that we've been playing basically at the nervous system, but also if you are really itchy, it's distracting, you can't concentrate, you don't sleep well, you're scratching in your sleep, it's waking up for your sleep. And, if I can't sleep, I'm definitely in a bad mood and can be, have some issues there. So we know that itch and poor sleep can also, and their decreased quality of life can lead to symptoms of depression and anxiety. And we know that depression and anxiety can correlate with AD severity, but the positive side of this is that if we can improve the atopic derm, then we can also decrease these symptoms of depression and anxiety. And so this kind of led to the statement that's at the bottom of the slide in the blue box in the guidelines that we just published that says successfully treating AD may alleviate depressive symptoms for some patients, and for others, assessment and treatment specific to their mental health may be needed. So again, to keep that in mind. So putting this all together, when we think about our goals of management for these patients that have moderate to severe AD, kind of the top bullets on the slide are really focused on the skin. So what can we do to improve their AD management? And so make sure they're doing proper basic skincare, daily bathing, use of emollients, avoiding irritants and, scented things. And then we also want to obviously treat and prevent any flares, and we do that with skincare and topical therapies, repair and maintain the barrier, again, with emollients, as well as our topical steroids and other therapies. And then as we do all of that, we will achieve and maintain freedom from flares. And that means keeping the skin clear. So let's get the skin clear and keep it clear. And if we do that, then we can start to, think about the patient as a whole and not just their skin, but make sure we've enhanced their quality of life and their satisfaction with their treatment. And make sure patients are involved with the decision-making, meaning what therapy do they want to use? And then with that, we want to assess and manage their comorbidities. And the most important thing is that, managing AD, especially moderate to severe AD, is hard and it can take time. And so we have to make sure patients can tolerate the treatments and they can keep up with the regimen. It doesn't matter if I have this amazing treatment regimen that will work and it takes an hour a day and the patient just burns out, like they just can't keep up with it. So we just want to make sure they can keep up with the regimen that they have. Okay, so now we have our first audience poll question of the presentation. And so the question is, what is the most common comorbidity of moderate to severe AD that you see in your practice? A is allergic rhinitis, B, anxiety and or depression, C is asthma, D, cardiovascular disease, E, food allergies, F, sleep issues, G is other. And just to kind of start this off, I can say in my practice, I see all of the above, really. And so, and maybe related because I'm a pediatrician and because of my research expertise, I definitely see a lot of food allergies, asthma, and sleep issues. Dr. Lamb, what about this? What do you think about this list? Does this surprise you? Does anything jump out at you when you see this?
No, these are really consistent. I think the allergic rhinitis and the asthma are really some of the key ones. And then the other often is just lifestyle disruption. So work and school, those are high on the list as well. I would put those under the other. That's often what will bring, especially adults, into the practice, is that they feel like they're having to miss work. They can't function. They, can't go about their activities of daily life.
Yeah. And I think our experience looks like it's matching with our audience, where answer C is the most common, which is asthma. Okay, so when I think about this, when we talk about this as from an allergist perspective, so as I mentioned, the most common comorbidities I see in my practice, and again, I'm a pediatric allergist and my research is focused on atopic dermatitis and food allergies. So I see a lot of food allergy, allergic rhinitis and asthma, obviously, because I'm an allergist, and maybe also related to age, I see a lot of sleep issues and behavioral issues, including ADHD in my young ones or difficulty sleeping. And we all know when the child doesn't sleep, mom doesn't sleep either. So I definitely see that. And I think patients often come to see me as opposed to you or a dermatologist, and they have an agenda and they're looking to identify what are some triggers of their AD, whether that could be a food or an aeroallergen. And they often will have other allergic comorbid conditions. And so I can try to help them with all of those things, including their asthma, rhinitis, conjunctivitis. And I see a lot of feeding difficulties, difficulty with feeding and things like that. And so my patients are often using a lot of skin creams, or they don't know how to use everything that they have. And so they're trying to kind of really understand that. And often, I don't know what your experience is, but when they get to see me, they're trying to find what's the cause or what's the cure. And so I have to talk them through that. And sometimes they may perceive an association with a food or environmental trigger, but we have some very recent data that we just recently published that oftentimes, food allergy and AD are often co-expressed, absolutely, but the food as the sole trigger of the AD is actually really rare. So that's just a really important thing to mention, that although food allergy and atopic dermatitis can go together, true food triggered atopic dermatitis, where the food is the main trigger, is uncommon. So when someone comes to see me, I really spend a lot of time on education, just sharing that data with my patients, including the risks and benefits of skin testing for foods and aeroallergens. And I spend a lot of time in my visit to talk about this. So just to remind everybody really briefly that if we do testing for foods, the negative predictive value of the test is phenomenal. It's 94 to 99%, depending on the study you look like. So if you test negative to the food, I can tell you with 99% certainty you're not allergic. Before I even place the test on for my families, I make sure they understand the second bullet point, because it's crucial. And that is the positive predictive value is terrible. It's 30 to 50%. There's a 50% false positive rate for these tests for food. So if a child tests positive, I always tell my families we're going to follow up with a blood test or a specific IgE level, and likely some sort of oral food challenge, whether that's in office or at home. And I think this is really important, because you have to set the stage, because otherwise if the family sees that positive test, it's over. So you have to set the stage so they know how we're going to interpret that test. And then finally, very briefly, with aeroallergens, perennial allergens, meaning indoor, or allergens that are present year-round, dust mite, cat, dog. We usually start seeing that around 1 year, but true seasonal allergies where pollens are triggering something, that usually doesn't start till they're 2 to 3 years old. They just need to be alive for a couple of seasons before you start to see that sensitivity. So with that, Dr. Lam, I'd love to hear what you think from a dermatologist perspective.
Definitely, I agree 100%. I often tell patients that I work in tandem with many wonderful and skilled allergy immunologists like you, and I tell them when they're trying to zero in on that food or something that may be causing the atopic dermatitis, I say, certainly I'm going to send you for the testing, but I give them guardrails for that. I say that even a lot of studies have shown, even if you do have a frank food allergy and you eliminate it, you still have atopic dermatitis.
Absolutely.
So we're going to manage your allergies, which might be causing some other symptoms, and certainly maybe be contributing to the atopic dermatitis, but we're also really going to try to make sure that we get your skin healthy with some of the things that we're going to be talking about as we go forward. So the most common comorbidities I see in my practice are the allergic rhinitis and the asthma, as we talked about in the previous slide where we took the poll. These patients tend to come to me because they have more severe skin disease. When you're really covered, you have almost erythroderma, you again are getting to that place where you can't go to school, you can't go to work because you feel like you can't function. They usually feel like this is a skin thing, and I really want to come see a dermatologist. Also, it depends on philosophically whether they see it as a skin disorder. I think there are kind of two camps, like you mentioned, Dr. Singh, folks that see it as something internal that they need to fix and nail, and then that will make it external, or people who feel like there's something attacking them from the outside. I think folks that feel like it's more external are going to lean more towards a dermatologist. For the itching and the rough skin, depending on how they actually look, they tend to see a dermatologist as well. So I find patients that are more predominantly itchy, they are going to lean more to an allergy immunologist. They see that more as, again, that internal. But people whose skin looks horrible, they're going to come to a dermatologist. And then often their complaints and treatment goals tend to be slightly different. They may have already seen an allergist. I find there's that camp of patients too who go to see an allergist first. They've tried maybe at home to do some food eliminations, but they still are very uncomfortable, and again are having the way their skin manifests really limit their ability to enjoy their quality of life. And then I think that patients who see dermatologists first tend to see us for more mild skin disease if they're not quite as itchy. So let's really try to unpack some of these treatment options and which ones are appropriate, because now we have so many things in our armamentarium that we can use to treat atopic dermatitis. This is an exciting time. I mean, I just have really been able to change lives more in the last several years because of some of the recent pharmaceutical advancements. But before we get into that, I'm kind of piggybacking on the cartoon that Dr. Singh went in, where I love that cartoon because it really breaks down how you have the different mucosas that come together to create our clinical disease that we see. This zeroes in on that one kind of skin section to really see. So, what are we seeing clinically with atopic dermatitis? So you see that that itch, which we have here at the top right. But why is the skin itching? So the barrier repair, so a lot of the proteins, the filagrins, the natural decrease in natural moisturizing factors, which we think a lot of this is genetic, decrease in the long chain ceramides. A lot of the emollients that we use, of course, have these in them and are really targeted, as Dr. Singh mentioned, when we're targeting, really helping people understand the importance of barrier protection. It's all really going back to the science and what we know about what causes atopic dermatitis. You really have an intrinsic defect in the body's natural ability to do these things. All of that increases transepidermal water loss, which decreases your AMPs. And then you really have this cytokine cascade and really that upregulation of the Th2 arm that gives you what we see clinically. And just that cycling. I always like to say, and I'm borrowing this term from one of my mentors, atopic dermatitis at its fundamental is the itch that rashes. So I love how they show that there's that itch at the top, which then creates this whole cascade, which is built on the fact that these patients intrinsically do not have some of the things that they should. Again, the filaggrin, the long chain ceramides. And then we're harnessing a lot of this, which we'll get into in subsequent slides, to really treat the atopic dermatitis in ways that we have not before. All right, so the new and emerging biologics for moderate to severe AD. So really one of the first ones to hit the market was the dupilumab, which, as we know, is an injection, different dosages based on age. You have this IL-4 target, and this is really indicated for patients who are 6 months old and up, which is incredibly exciting. I have many pediatric patients, as I'm sure Dr. Singh does as well, that are on this. Of course, we look at the FDA-approved indications, and what's nice is dupilumab has multiple. So as we'll get into when we walk through some of the cases, these would lean us one way or another. Then we have several that are coming down the pike. And again, we're incredibly excited, but then we'll jump down to tralokinumab, which is also an injection that targets that IL-13. Unfortunately, this is only indicated for adult patients with, of course, disease. The criteria is the same, disease not well controlled with topical therapies. But again, you can see with this slide how we have some exciting ones that have not hit the market, but two very strong ones that we're incredibly excited about. So the mechanism of action, we're really harnessing a lot of, as we talked about on the previous slide. So for dupilumab, I'm just going to jump to kind of the left and the right, the two that are on the market for dupilumab and tralokinumab. You're really harnessing that IL-4 in some, and then also actually for tralokinumab, you're getting at the actual cytokine. You're not only binding the actual location, but you're getting at the cytokine. And then we have the lebrikizumab, which again is pending, that also here has that IL-13 alpha binding here, and also binding to the receptor site and the cytokine. Okay. So I'm going to turn it back over to Dr. Singh now to just really help hone in here some of what we'll be talking about later, which is how we would take all of these medications and really go for one over another.
Yeah, so absolutely. So thank you so much. And I think as Dr. Lamb just discussed so eloquently, like there are several biologics that have been either approved or under investigation for AD, and that's kind of this orange, the orange circle or the orange part of this Venn diagram. And then there are other biologics that have really targeted kind of the Th2, the immune system, which are on the left hand or the blue Venn diagram. And you can see what's really nice is that dupilumab, or the IL-4 receptor alpha antagonist, has approval and shown efficacy for both asthma and atopic dermatitis. And it's really our only one. And, you know, something that's really unique about dupilumab is it's the IL-4 receptor antagonist, and IL-13 also signals through the same receptor. So you really get inhibition of IL-4 and IL-13. And so again, this is just illustrating that that dupilumab is really a good choice when we have multiple diagnoses. And this led to our guideline statement, as listed at the bottom of the slide, that targeted therapies that are effective for both severe AD and asthma, such as dupilumab, have the potential to benefit patients who have both conditions. And so this is just some data kind of illustrating how you can kind of get that benefit. So this is a post hoc analysis of basically the four main large randomized controlled trials in moderate to severe AD, SOLO 1, SOLO 2, Crohn's, and CAFE. And in these studies, patients in SOLO 1 and SOLO 2, they received placebo or Dupi either at the 300 milligrams every 2 weeks or 300 milligrams weekly. And in Crohn's and CAFE, they also received concomitant topical steroids. And you can see a lot of the patients had other diseases. Over 400 had asthma, over 1,000 had sinonasal conditions such as allergic rhinitis, and over 300 had both. And so this is at 16 weeks. This is the ACQ score, the asthma control test, basically. And what you can find is that among patients who are getting dupilumab for their atopic derm, so they're getting prescribed for their moderate to severe atopic derm, while they're on the dupilumab, by 16 weeks, we see a significant improvement in their asthma control, or their ACQ. And so here, the light blue bar shows the 300 milligrams every 2 weeks, and the purple bar shows the 300 milligrams every week as compared to placebo. And you can see that significant improvement. In addition, there's an improvement in the SNOT-22, and this is our allergic rhinitis, these kind of clever snot. So this is our test for rhinitis, and again, you can see significant improvement in rhinitis symptoms. And again, these are patients where the primary indication was AD, and they had improvement in their asthma and their rhinitis at 16 weeks. And so that's short term, 16 weeks. So what about long term? My lights There we go. My lights just went off, so I wanted to turn those back on. So what about long-term? And so this slide now illustrates the long-term efficacy of dupilumab in adults with moderate to severe AD. So this is 204 weeks. So we just fast forwarded from 16 weeks to 204 weeks. And this slide shows the percent of patients that achieve either 50%, 75%, or 90% improvement, as illustrated by the EZ50, which would be 50% in the blue, the EZ75 in the red, and the EZ90 or 90% improvement in the green bar. And you can see patients achieve this improvement and they can maintain it. And they are maintaining it for 204 weeks. And what's really nice is that as far as the safety profile, adverse events, they're pretty consistent, and there's an acceptable safety profile for up to 4 years while they're on the dupilumab. So this is focused on adults. What about younger patients? So now we're just going to kind of back up. So if we start with the right-hand side of the slide, these are adolescent patients, so 12 to 18 years of age. And this is showing patients, again, that achieve EZ75. And you can see a significant improvement, over 40% that achieve the EZ75 in our 12 to 18-year-olds. And now if we back up even younger, so now we're at 6 to 11 years of age, and we can see the response is even better. So we see, somewhere between 65 and 70% of patients will achieve an EZ75 or a 75% improvement in their atopic dermatitis, even at age 6 to 11. And again, it was safe. So the safety data was consistent with our adult trials and the previous dupilumab studies. And so now we can even go even younger. And so as Dr. Lamb mentioned, dupilumab is approved down to 6 months of age. So here's the data that's looking at patients, young children, 6 months to 5 years of age with uncontrolled moderate to severe AD. And you can see there's a significant improvement in itch and the EZ75, as well as a third get clear or almost clear skin. So that's, fantastic, especially these young kids. They often have really severe disease. And as I mentioned, if the child isn't doing well, nobody in the family is doing well with regards to sleep and all of that. So, overall, again, showing efficacy in this young age group and safety. So there are similar percentages of adverse events in each group, and there were no dupilumab-related adverse events that were considered serious or that led to discontinuation of the drug. So they were able to stay on the drug. They have improvement basically in all body sites early, even by week 2. So head and neck, trunk, upper and lower extremities, and this is sustained at week 16. And again, there are improvement in EZ score signs, including the redness, the erythema, excoriation, infiltration, and all of that is improved. So again, illustrating the efficacy and the tolerability of Dupi even in these young groups. And then finally, the Liberty AD half study, which was in adolescents with moderate to severe, adolescents and adults, I should say, with moderate to severe AD who had difficult to treat areas, meaning the hands and the feet that can often be difficult to treat. And again, shown significant improvement at 16 weeks, with 40% achieving clear or almost clear skin on the hands versus 17% in placebo. And again, over 50% with an improvement in their pruritus or their itchiness. Improvement in lesions, so almost 70% reduction in total lesion score signs, and a 75% improvement in the hand eczema severity index from baseline compared to 40% of placebo. And obviously, if you make their skin better, then they feel better, right? So these patients also have improvements in their, hand and foot pain, sleep, and quality of life. So with that, I'm going to turn it over to Dr. Lamb, and she'll talk to us about some of the other biologics.
Yes, so that's a great tee up. We really walk through the long-term safety data and the high quality of the, like I said, kind of our first game changer biologic for AD, dupilumab. So now we'll transition to tralokinumab, and this really looks at kind of a three-arm. So we had placebo plus topical steroids, tralokinumab given every 2 weeks plus topical steroids, and then tralokinumab every 2 weeks plus topical corticosteroids slash tralokinumab every 4 weeks plus topical corticosteroids. So we really see here how, of course, the orange, the placebo plus topical corticosteroids were not nearly as effective at getting clearance. And then, of course, you see here at 16 and 32 weeks long-term data on how folks did. They improved. And what I find really nice about tralokinumab is just this idea that after 16 weeks, people can transition from Q2 weeks to Q4, which a lot of patients I have found to really enjoy that. And then here we look at the long-term safety data. Again, this is pretty much a year. So not only do we want to get people better, but we want to get them better for a long time and also in a safe way. So look at how this really illustrates that even, like it says here, the 56 weeks, but also when we look at the 2-year median data, patients were still doing incredibly well. And the safety data reported were consistent with placebo-controlled trials, but adverse events occurred at lower rates. And then fewer patients discontinued due to any adverse events, which we talked about several slides ago, really have to do with mostly the ocular involvement or injection site reaction, or people getting a few more colds or minor illnesses per year. And this really looks at the efficacy of lebrikizumab in patients with moderate to severe AD, again, over 52 weeks. The results are combined with these 2 studies. So you have the Advocate 1 and Advocate 2 in adolescents and adults. And then it really shows that patients responded quite well to lebrikizumab, 250 milligrams every 2 weeks at the end of a 16-week induction period. And then it shows how not only are we looking at EC score, but we're looking at, you can see here on the top left, IGA 0 to 1, so going a 2-point scale, so how patients actually improve. So if you are at, for example, and a 2 getting to a 0 or a 1, or if you're at a 3 getting to having to jump 2 points. And so you can really see here across the board that these medications work, and they work well, and they get patients actually quite significant relief and improvement. This really is a nice slide because it talks about and it amalgamates some of the major adverse effects. So as I mentioned, so dupilumab and I find tralokinumab, I'm going to go kind of from the first bar here to the last. Injection site reaction, the conjunctivitis, which we see across the board, blepharitis, some of that eosinophilia, the minor infections, so upper respiratory tract infections. So when I'm kind of trying to compare those head to head for patients, because of course, if you're going to talk injections, usually talk both at the same time. For patients, for example, that do not have asthma, because then I would of course pick dupilumab, I really say to them that a lot of the side effects are pretty similar. And again, the one that I see clinically the most is this conjunctivitis. And as you see here, if we go through the asterisk ones, the ones that are in trials, we see some of the same. So the conjunctivitis and nasopharyngitis, the allergic reaction, the herpes virus infection, which we see in many of these biologics, mostly because, we're thinking of the decreased immune system, and headaches, ulcers, and nausea we can see as well. But again, this is pulling out the most common adverse reactions, but these are incredibly rare. The new and emerging JAK inhibitors for AD. So these are incredibly exciting because this gives patients a non-injection option. So we have aducanumab, which is a JAK1 inhibitor. This, again, the indications are all relatively similar for moderate to severe AD. What's nice is these are indicated for patients 12 and above, which is exciting because we often didn't have a lot of safe options for folks in this category. And this this barakinumab, which is a JAK1/2. This is under FDA review, but of course, as we all know, this is, we're currently using this to treat alopecia areata, and I have several patients on this. But of course, as we're seeing with a lot of JAKs, they have more than one indication, or are in the process of getting more than one indication. And then upadacitinib, which is a JAK1 inhibitor, also 12 and up, which was used for years to treat RA. And so we're excited to have this as an option now for atopic dermatitis. So this is just a study that walks us through abrocitinib in adolescents and adults with moderate to severe AD. This is the JADE Mono 1. And what I find so impressive about the oral JAKs is that not only do they work, but they work incredibly fast. So when you really look at the EC scores and how fast, if you look at kind of the angle on this, people get, they get better, and they get better very quickly. So if you're looking at week 2, 4, 8, 12, look at how quickly we're right up to week 2 with getting that improvement with the EC score. And of course, comes in 2 dosages, both the 100 and the 200. We see, of course, 200 works better, but I start everybody on 100. Then we're looking at abrocitinib versus dupilumab in the JADE compare, really showing that adverse events occurred at a higher percentage in the higher dose of abrocitinib group versus placebo in the dupilumab groups, and are similar in lower dose abrocitinib and dupilumab groups. So again, what I love about this is this compares placebo, so the gray, patients not doing so well. And then as you go from abro 1 to 2, and then dupilumab, you really see that the abrocitinib at the 200 milligram daily dose really, knocks it out of the park. And again, look at the angle here. Patients are feeling much better and have improvement from baseline at a nice angle there and very quickly. And that itch response too, which I find to be, again, with AD being the itch that rashes, that fast response is what patients want. They want something that's going to work quickly and keep them safe long-term, which all of these medications really provide. So this is long-term, looking at 48-week efficacy of abrocitinib. And again, so you want something that's going to have lasting effect, not just work and then, in a couple of weeks, I'm back to where I was. And this just shows that these work, and they work for a long time. Of course, as I mentioned, the 200 dose does get people clearer, but it's appropriate to start everyone at the 100 milligram dose and then take it from there, because we want people doing well at the lowest effective doses. And then this is looking at the baricitinib results from the BREEZE trials for moderate to severe AD. And these are patients who had an adequate response to topical corticosteroids, so it improved their symptoms, mostly itch. So that rapid reduction of itch is often what people want. They want their skin to look better, but if they can't sleep and they can't function because they're scratching all over, that's really such an important target. And that's what I have found that the JAKs have been able to do in a very superior way. It's that rapid onset of the itch improvement that I've been so impressed with. And this is really looking at the upadacitinib plus tricyclic, for topical corticosteroids in moderate to severe AD. Again, looking at it up to 52 weeks for the results. And so we've had long-term safety data of this medication with RA, but again, as I mentioned, now using it for atopic dermatitis, and at the 2 dosages, again, a higher dose will always work better. But again, we see, I can't help it coming back to this, how quickly people get improvement. So look at this 2-week here, and the EC score of 70, you're getting up here, the percentage of people that are getting up to 75, it's incredibly impressive. And again, we always start patients on the 15 and titrate up slowly, but if they can get control at 15, we try to keep them there. So again, this is also looking at this medication for efficacy and safety. So what I like about what we're talking about right now is we want to reiterate to everyone that these medications, you want to feel comfortable with them. You want to know that they're going to work for patients. You know, if you're going to take those risks and do the monitoring, you want to be able to tell people that not only does it work, but it works safely, and that we'll keep an eye on you. We're going to select the medication that's appropriate for you. But these just really drive that home. So again, when you look at the blue, the 15, and then you look at the black, or actually, is that green, or that might be dark green. Looking at how well people do with sustained improvement and relief for 52 weeks. So again, this compares the effectiveness of systemic treatments in moderate to severe AD with topical corticosteroids. This is really a meta-analysis. So just the brief snapshot of this is, our primary endpoint was 12 weeks for abrocitinib and 16 weeks for all other therapies. It did not evaluate the overall symptom severity, but the safety, benefit, risk, and patient preferences should be incorporated into finding a treatment plan that's good. But if we look here, of course, our placebo didn't do well. But as we go step by step, comparing all of these new medications that we have at different dosages, we really see that patients are getting both the EC75 and 90. Large percentages of patients that in this quality of life scale are doing very well on these. And I love how it compared these, looked at a really took all of the data in a meta-analysis and said, hey, this really, of course, we need to decide what's best, and we'll get into that. So looking at how we are going to pick out of this nice group of medications we have. But it really shows that these are game changer medications and are really changing people's quality of life. And again, the most common side effects of JAKs used in atopic dermatitis, the nasopharyngitis, the headache, the acne is really a thing that I do see in my practice. And then the herpes simplex, as we talked about, decreasing the immune system. So I won't read through all of these, but you can see there's some consistency across the board in the ones that you get. The acne, the headache are the ones that I see most often in my practice. And then, how do we counsel patients on the boxed warning? So when they, we're giving them a JAK and they say, hey, is this used for cancer? Why are you giving me this? I thought you were trying to help my skin or my condition. And I think one important takeaway is that several of these medications were used and treated for other conditions and patients that had other comorbidities or other autoimmune conditions, particularly for RA. So the increased risk of serious bacterial, fungal, viral, and opportunistic infections, including TB, again, because of decreased immune system. They're there, but they're rare. We don't have time in this type of talk, but the studies are referenced below to really unpack all of that data. But you're talking about like one or two cases. I mean, long-term, we're looking at sometimes thousands of patients. Again, the selection bias, there's a higher risk of all-cause mortality, including sudden cardiovascular death, because these patients tend to have more inflammation. The higher rate of lymphomas and lung cancer, and then the major cardiovascular events, and then the thrombosis or increased incidence of embolism in venous and arterial thrombosis. And when we really start looking at some of the cases and unpacking how we would select one patient over another, that's going to be really important because these risks are there, although they are incredibly mild or rare. You certainly don't want to give one to a patient that has a higher risk factor. Now let's just transition to an audience polling question again. So which one of the following agents would you recommend for a 19-year-old woman with depression and worsening atopic dermatitis, worsening moderate to severe atopic dermatitis, despite the use of corticosteroids? So Dr. Singh, I'm curious, I'd like to chat with you a bit while we're getting those results in from the audience and listeners. What do you think? I mean, are a lot of your patients coming to you having tried and failed corticosteroids and are pretty desperate?
Yeah. And I think this question really, to me, highlights, what are the comorbid conditions that maybe this patient might could benefit from some help with. So maybe it looks like if there's not other history, like depression is the main one, and then shared decision making, kind of the role of shared decision making in this process. So
Sure. So I don't see where the polling results are coming in. I don't see any.
oh yeah, sure. So the most common answer is B
Oh,
for the poll, which was dupilumab. So we can kind of talk about this. So what is it? So kind of moving on, like what is it that what are some of the other effects that some of these medications can have on anxiety and depression? So if we start with the data on abrocitinib on anxiety and depression in adolescents and adults, and basically using this HADS depression score, you can see that there is an improvement in patients who are treated with abrocitinib, and this is from the JADE Mono 1 and JADE Mono 2 studies, where they have an improvement in both their depression and anxiety. And we also can see improvement with Dupi as well. So dupilumab also effects of dupilumab on anxiety and depression. Here, this is adults and adolescents again. And here you can see that patients who are treated with dupilumab compared to placebo have an improvement in their depression and anxiety scores. So kind of moving on now, like just kind of thinking about, the real life patient that's in front of us. When do we choose the biologic? If so, which one versus a JAK inhibitor? And if so, which one for moderate to severe AD? So which agent is best in each case? And so if I start with the first case, a 5-year-old with comorbid asthma. So right away, age is a determinant for me. So as far as, an FDA approved product in that age group. And then when you think about the comorbid asthma, I think dupilumab would be a great choice for this patient. It would involve some discussion. It is an injection. And so what are some of my injection strategies? Bribery works, but besides bribery, the Busy the Bee, I don't know if you guys have heard it. You can order it from Amazon and you put it proximal to the injection site and it vibrates. And what you do is you kind of overwhelm the nerve with the vibration. And so they're less likely to feel pain. Icing beforehand treats all of that.
yeah.
And so if you want to do the next case, Dr. Lamb.
Sure. So a 65-year-old patient with cardiovascular risk factors. As we've been walking you through all of our new and exciting options, again, so how do you pick? Really, the atopic dermatitis cardiovascular risk link is real. So systemic inflammation is a true risk factor for cardiovascular disease. So actually targeting the inflammation can decrease the risk of cardiovascular events. So we really see here that there are small associations between AD and, of course, hypertension, cardiovascular disease, congestive heart failure, myocardial infarction, and then cardiovascular death. And so I think you have to take those things into account when you are trying to select one of these agents. And so for that one, I actually would select either tralokinumab or dupilumab for that patient. I'm going to go ahead and advance the slide. Then let's walk through this 25-year-old patient with alopecia. So we touched on this a bit, that we currently are harnessing JAK inhibitors and are actively prescribing them to treat alopecia areata. And so for this patient who has another condition, what I would give her would be an oral JAK. So likely abrocitinib for that patient. Any comments on that, Dr. Singh?
No, I agree, especially with the alopecia. So thinking about the 14-year-old patient with no comorbidities, this really becomes shared decision-making, injection versus oral. The other piece about this would be, frequency. How often do you need to take the medication? And to me, the JAKs have more off-target effects, and they're designed to be that way. So JAKs are downstream from the cytokines, and so they inhibit more things. So thinking about, the role of acne, are they finished with their vaccinations? Kind of those sorts of things would go in. And honestly, I probably would recommend Dupy just because of the safety data. But it also depends how itchy is the patient. If they're really itchy, then maybe the JAK is better. So it becomes kind of some shared decision making.
Yeah, and that goes along with what we were saying about we have found that the JAKs get people itch relief faster. And so that I think just to kind of bring that back home, why we would pick one over the other in that case. So now let's transition to a 55-year-old patient who refuses an injectable and has a family history of cardiovascular disease. In this patient, I would likely treat with abrocitinib, mostly because of when we're looking at some of the other JAKs, they do have some increased risks there with the thrombosis and some MACEs. And so for this patient, there will be less risk of that. And so I would select abrocitinib. All right, so here are the roles. I'm just going to touch very briefly on, frankly, looking back to look forward. We had many things before the traditional immunosuppressants that I prescribed 15 years ago with frequency for patients. So we had azathioprine, cyclosporin, methotrexate. I just actually 6 months ago transitioned a patient from methotrexate to abrocitinib. Then we had mycophenolate mofetil. These were what we had to reach for. And then look at these toxicities for patients and the monitoring that we had to do and some of the large potential side effects. I mean, these agents were not FDA approved for AD, but we were using them off label because we really didn't have anything else to use. And the thing is that these would blast people's immune system. So you're suppressing the entire immune system really to get improvement and change in quality of life for patients. And it's just exciting that, frankly, we just don't have to do that anymore. So traditional immunosuppressants, I do reach for them sometimes, unfortunately, due to lack of insurance or healthcare access. These medications we're having, I just got an email saying that now for a lot of the biologics, they want a RAD score. And so in addition, I thought we had got that with the EC score or the body surface area, but insurance companies are really giving us some challenges with coverage. So the patient is well controlled on an immunosuppressant and maybe doesn't want to switch, or for short-term efficacy, if we really just want to get that improvement within a couple of days, sometime we may reach for that because, or as a bridge until we get the other medication approved, because as we know, sometimes it can take quite a while to get these approved. So looking at the impact of effective treatment of moderate to severe atopic dermatitis, now we've really walked you through the options, the side effects, kind of what we've used in the past. So how do we really transition to how do we pick? We had a couple of questions before, but we'd like to delve into that a bit more. I'll take these first two cases. So case one, a 30-year-old patient with moderate to severe AD. She has itching on her eyelids and does not have asthma or another type 2 comorbidity. She's tried and failed topical agents, steroidal, non-steroidal. I would select abrocitinib for her, mostly because, unfortunately, we've seen with the 2 injectables on the market that sometimes people get a strange, almost rebound. We're not quite sure why this is happening, and I want to, in the interest of time, not delve into the science and pathway that we think is going on with that. But I would want, she has a difficult to treat area. She is itching. She's tried other things, and then we tried this and she significantly improved after 3 months. And then we have a 60-year-old patient with moderate to severe AD, cardiovascular disease, and a long history of asthma. This patient had difficulty keeping up with her medications, including beta blockers and statins. So for her, I would do tralokinumab, again, because I don't want to put her on something that could potentially increase cardiovascular risk at all. And she also was improved after 3 months.
So here are a couple of cases from my perspective, very briefly, given the time. My first case is a 3-year-old who had moderate AD, and she also had mild persistent asthma and EOE. And so, I was treating all of her diseases, topical steroids for her skin, some low dose fluticasone for her asthma, and her GI doc was having her do swallowed budesonide. And she ended up being a really poor eater. She was a peanut. She was at the bottom, below the growth curve, less than 2nd percentile for height and weight. Because of all of this, I checked a cortisol, which was slightly low. And so I was like, you know what, this was starting to affect her adrenal axis. And so she really needed something else, and we were able to start her on dupilumab. Family is so happy. She has grown a ton. She's currently 10th to 15th percentile now. She's eating, she's thriving, she's doing better, more energetic. She's just doing fantastically. The second case was a 16-year-old with moderate towards the severe AD and with some depression. She was scratching all the time. She had a lot of skin lesions, and I think this was impacting her sleep, but also she was a teenager and she hated the way she looked in gym class in school. And she was missing school because of her AD, and she also hated needles. And so for her, we went with upadacitinib, and she's doing much better, and the itch is better, and she's very happy. And so given the time, we really just have time for one question. And the question is addressed to you, Dr. Lamb, which is, in a patient with comorbid asthma who is hesitant to use an injectable agent, how do you discuss the pros and cons of using a biologic?
Comorbid asthma. So let's go back to, unfortunately, it would only be an injectable that would be appropriate for that patient. But if they do have the phobia and we're trying to figure out how to navigate that, really how I try to bring patients around is I say that these medications are safe. And like you had mentioned, some strategies to try to convince them that if they also have AD, AD and asthma, they're going to want something that covers both, and nothing is going to really do that besides an injectable. And I think just the strategies, dealing with the coping strategies, there are some, calming things that you can talk to patients about, some cognitive behavioral therapy that they can go through if they're dealing with the phobia. And then if they really are not willing, say, hey, we can treat your AD, but understand that you're going to have to do a separate medication to manage your asthma, and really just talking them through that. And if they want to do that.
Fantastic.
All right. So thank you all for participating and joining us today. This has really been a lot of fun. We've enjoyed everything, and our audience. I also want to thank Sanofi and Regeneron Pharmaceuticals for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com to view today's session along with other sessions on demand. My name is Dr. Angela Lamb. Thank you again for joining us, and thank you again to Dr. Singh.
Thank